Welcome to the IDF Europe podcast, brought to you by the International Diabetes Federation Europe. In each episode, we explore important topics related to diabetes, from the personal experiences of those living with the condition and healthcare insights, to research, innovation and health policies across Europe. Whether you are living with diabetes, a healthcare professional, or simply interested in learning more, this podcast is for you. In this first episode, we are joined by two incredible guests, Dr. Benedetta Armocida, coordinator of JACARDI, the EU Joint Action on Cardiovascular Diseases and Diabetes, and Dr. Helena Safadi, leader of the JACARDI Work Package 9. Together, they will explore what integration of care means, why it is important to improve the quality of life of people living with diabetes, and what is needed to implement it effectively. With that, I would like to welcome Dr. Armocida and Dr. Safadi, and thank them for being here with us.
Thank you very much for the invitation. I'm delighted to be here. My name is Benedetta Armocida. I'm a physician and public global health expert from Italy, with a background in global health, health policy, and health system strengthening. Over the past years, my work has focused on understanding and addressing the burden of non-communicable diseases, particularly diabetes and cardiovascular diseases, both in Europe and globally. I'm currently a senior researcher at the Italian National Institute of Health, and I'm coordinating JACARDI, the Joint Action on Cardiovascular Diseases and Diabetes, which brings together 21 European countries to share best practices and pilot innovative approach to prevention, care, and management of diabetes and cardiovascular diseases. What really drives my interest is how we can make health system more equitable, resilient, and responsive to the needs of people, with a specific focus on adolescent and young people who are living with non-communicable diseases like diabetes. And now I pass the floor to you, Helena.
Thank you, Benedetta. Hello, everyone. It's great to be here. And let me also extend a warm welcome to all of you. I am Helena Safadi, a physician and an economist with a primary focus on healthcare management, particularly quality management and patient safety. Over the past few years, I've been working on developing and implementing best practices in hospital settings, and I've also been exploring how big data could play a role in improving diabetes care in Hungary. Currently, I work at the Hungarian National Cardiovascular Center, where I have the privilege of leading Work Package 9 of the JACARDI project, alongside my wonderful colleagues, of course. Work Package 9 focuses on integrated care, which is a really exciting challenge. It gives us a unique perspective on where the care pathways could be improved across Europe, and also lets us look into various possible solutions and the details of their implementation processes. But before we dive deeper into integrated care, since our listeners might not be very familiar with JACARDI, can you give us the big picture, Benedetta? What is JACARDI trying to achieve and why?
Of course, thank you very much, Helena. JACARDI is a joint action co-founded by European Commission, uniting 21 European countries with one shared ambition to reduce the burden of cardiovascular disease and diabetes. Running from 2023 to 2027, JACARDI brings together 81 partners from across Europe, reflecting a rich diversity of cultures, lifestyle, and health system structures. The initiative is organized into several key areas of work, from knowledge sharing and policy alignment to the design and implementation of pilot projects in real-world settings. The aim is not only to test innovative practices, but also to generate solid evidence and lessons that can be adapted and scaled across Europe. What makes JACARDI unique is that it follows the entire patient journey, from healthy people to those at risk of developing cardiovascular diseases or diabetes, to individuals already living with the condition and at risk of progression or multiple illness. Along this journey, the focus is on health literacy and awareness, screening and early detection, integrated care pathway, self-management, and participation in the labor market for people living with these diseases. And all of this is carried out under two guiding principles: equity and better availability, quality, and use of data, ensuring that no one is left behind and that decisions are informed by high quality and shared information. The project engaged a broad community such as Ministry of Health, public health institutions, universities, professional society, patient organization, and local health authorities. The real engine of JACARDI is its 143 pilot project. They test practical solutions on the ground, like strengthening primary care, improving self-management, or reducing inequalities, while generating lessons that can be scaled across Europe. Their purpose is twofold. First, to deliver tangible improvements locally, and second, to generate models and lessons that can be scaled beyond the pilot sites. In this way, the pilot acts as laboratories for innovation. They show what works, reveal what doesn't, and create a body of practical knowledge that can accelerate Europe's shift towards more person-centered sustainability and resilient care. So, in short, JACARDI is not only about improving care for people living with diabetes and cardiovascular diseases today. It is also about shaping the future of how our health system responds to non-communicable diseases, building approaches that are equitable, sustainable, and above all, centered on people's real needs.
Thanks for this great overview. And in your opinion, Benedetta, how does Work Package 9 and the broader theme of integrated care fit into the overall goals of JACARDI? Why do you think integrated person-centered care is such a crucial element in improving outcomes for people living with chronic conditions like diabetes and cardiovascular diseases?
Well, that's a very important question. When we talk about conditions like diabetes and cardiovascular diseases, we are talking about lifelong complex conditions that often occur together and are influenced by a wide range of socioeconomic determinants and biological factors. This is why focusing on integrated person-centered care is so crucial. People don't experience their health in separate compartments, and yet too often our system delivers care in silos. In my view, truly integrated care means that people living these conditions experience their journey as continuous, coordinated, and supportive, whether they are in prevention, diagnosis, treatment, or long-term management. Unfortunately, many of our health systems remain fragmented and oriented around acute care or single diseases. This has historical reasons. Systems were designed to respond to infectious and emergencies, not the reality of multimorbidity and aging populations. The consequences is that people with multiple chronic conditions often face duplication of tests, conflicting advice, poor communication between providers, and ultimately inequalities in access and outcomes. This is precisely where JACARDI and the Work Package 9 on integrated care pathway come in. Our goal is to help countries shift the paradigm from fragmented, disease-centered models toward more holistic, person-centered, and resilient health systems. Through the pilot project, we are testing practical ways to strengthen integrated care pathways, improve collaboration across providers, and empower people to better manage their conditions. The idea is to show that integrated care is not just an aspiration, but is achievable, scalable, and essential. At the heart of this transformation is a simple but powerful idea. When we design care around people rather than diseases, we not only improve health outcomes, but also reaffirm dignity, trust, and solidarity as the foundation of our health systems. And now, Helena, let's zoom into the Work Package 9. Can you walk us through the work of the Work Package 9 that you are leading? What is the overall goal? Where are the pilot sites? What kind of challenges related to integrated care are they trying to address? And could you share a few examples of the approaches they are testing?
Of course, Benedetta, thank you. So the main goal of our work package is to improve the diagnosis, treatment, and management of diabetes and cardiovascular diseases through pilot projects that develop integrated care pathways across Europe. We start each pilot project with a thorough situation analysis and patient pathway mapping at each site. This helps us identify the key areas in the care process that need improvement, understand the local context, and pinpoint the relevant stakeholders. Then, to develop tailored solutions, we also look at the available evidence that includes existing best practices, relevant programs, and scientific literature that could guide our interventions. Based on this evidence, each pilot site designs its own improvement package, adapting these insights to fit their specific context and resources. Once the packages are finalized, the pilot interventions are implemented and evaluated across multiple dimensions. The idea is that if these pilots prove successful, they can be scaled up to other sites, institutions, regions, or even countries, and potentially extended to support the care of other chronic conditions. All of this is being done through the implementation of 29 pilot projects across 11 European countries, including Italy, Spain, Slovenia, France, Finland, Latvia, Belgium, Romania, Hungary, Iceland, and Poland. These projects are incredibly diverse. Several pilots focus on improving the transition period after hospital discharge. Other projects are centered around patient education or digital tools to support lifestyle interventions. Many strengthen the role of general practitioners in diabetes care or improve coordination and information sharing between different levels of care and among healthcare professionals, often using digital solutions. And finally, some are working on standardized documentation and indicator sets to make care more evidence-based.
Wow, Helena, that looks like a massive work to manage and coordinate. And tell us a little bit more on the Work Package 9 and particularly on the pilot. Are the problems addressed by the various pilots specific to their regions and health systems, or are there common challenges across countries? And what does this mean for the possibility of scaling up solutions or implementing them in different contexts?
That's a really interesting question. Thank you, Benedetta, for bringing it up. What we see is that across countries, projects are working on the same core elements of integrated care, such as multidisciplinary collaboration, patient involvement, decision support tools, IT solutions, or community support. But the way these are implemented looks very different depending on the local characteristics, resources, or cultural context. Take post-discharge care. In one region, patient follow-up might be organized mainly through general practitioners. In another, specialist doctors take the lead, and the hospital provides the care coordination. Elsewhere, dedicated care coordinators are introduced. So the principle is always the same: don't let go of the patient's hand. But the organization varies widely. That's why we put so much emphasis on understanding local realities. The pilot sites analyze their infrastructure, human, IT, and financial resources, existing care pathways, their stakeholders, and they identified barriers and enablers within and outside their organizations. In fact, the first year was devoted to this preparatory work. But even though the solutions are highly tailored, we expect them to be valuable for others because we are tracking and analyzing not just what works, but why it works in a given setting. This way, future implementers will have a menu of tested options to choose from, making adaptation faster and easier. And our hope is that many of these pilot projects will ultimately become recognized European best practices.
Thank you. Thank you very much, Helena. We really hope that many of the pilots will become European best practices indeed. And from your experience leading this work, what are the key components that make integrated care effective and meaningful? What must be present for a care model to be truly integrated and enable personalization? And how do digital tools help make this possible?
Thanks for the question, Benedetta. For me, integrated care means the coordinated operation of different components, levels, and actors of care across time and space, all tailored to the individual characteristics, preferences, and capacities of each patient. We know that chronic diseases like diabetes require complex care and lifelong management. No single profession can handle that alone. Dietitians and endocrinologists, GPs, nurses, physiotherapists, psychologists, podiatrists, diabetes educators, and the related specialists like ophthalmologists, neurologists, cardiologists, and so on. So they all have a role. It's easy to see how patients can get lost between all these points of care. Important steps or interventions can be missed if roles and responsibilities aren't clearly defined. On the other hand, duplication can also become a problem if the same assessments or tests are repeated across different providers because existing information is not accessible, shared, or validated. This can also lead to significant delays in care. That's why clearly defined roles, well-structured pathways, and information sharing are all essential elements. Still, even the best designed care will fail if a patient does not or cannot follow through. To earn a patient's cooperation, we have to equip them with the right information and skills. This is a resource-intensive process and one that does not traditionally fall within the scope of classic medical practice. But patient education needs to be a constant, ongoing part of care, delivered in a way that always matches the patient's current needs and situation. But I would even go one step further. Truly involving patients in their care also means we need to understand what they want and can commit to. People have different preferences, and in some cases, they might be willing to trade off a certain amount of health benefit for something else that brings them more happiness or quality of life. In other cases, people simply do not have the capacity to fully follow the recommended therapy due to their life situation, socioeconomic factors, or biological limitations. That's why it's so important that care plans are developed together with the patient, based on a thorough understanding of their personal characteristics and context, and with full respect for their reality. Digital solutions can really help here. They connect patients and providers, support decision-making, and make information available in real time. They enable closer monitoring and earlier interventions while also saving time. And they offer new ways to support patient education. So I believe that beyond a certain point, modern integrated care simply isn't possible without strong digital support.
Oh, thank you. Thank you very much, Helena. And now let's move into the present. So let's talk about today. And have any promising lessons or early results emerging already from the pilot? And what are some barriers you have encountered in implementing these new care models? What advice would you give to others trying to improve integrated care in their regions?
That's an exciting issue. It's still a bit early to talk about concrete successes, as most of the pilot projects have only been running for less than a year, but we already see some important lessons. One key factor is how implementation is managed. Some peoples are led by clinicians, others build on earlier project experience, some are led by public health institutes or care coordination bodies. I believe that by now, all of our pilot projects have recognized the importance of implementation. For example, we placed special emphasis on ensuring that stakeholders were involved as early and as fully as possible. Thanks to that, in some pilots where there were initial concerns that it might be difficult to recruit GPs or patients to participate voluntarily, they actually found that the interest was much higher than they expected. Another factor is leadership support. Without real support from senior management or government bodies, projects can work locally but remain hard to scale. This is a particularly critical issue because changes at these higher levels are typically beyond the control of the project teams and often unpredictable. What we have already seen is that the more significant delays and disruptions have often been linked to changes in leadership or institutional restructuring. Digital solutions also need to fit with the broader systems. Even the best tool won't last if it doesn't connect with the local and national infrastructure. At the same time, some outputs will be easier to transfer, like patient education materials or training for healthcare professionals. And we have research projects using existing databases and algorithm-based methods to detect risks earlier. So I would definitely encourage people to follow the activities and final outputs of JACARDI and our work package. And we are hopeful that in about 2 years, we will be able to share the concrete results of 29 successfully implemented pilot projects. But what I would like to ask is that, as we mentioned before, integrated care should be person-centered, which cannot happen without involving people with lived experience. I think it would be interesting to know how JACARDI is working to involve people living with diabetes or cardiovascular disease in shaping solutions. Could you walk us through this?
Thank you, Helena. I really believe this is one of the most important dimensions of JACARDI. If we want care to be truly person-centered, then we must start by listening to and working with people who live with diabetes and cardiovascular diseases every day. They know better than anyone what it means to manage this condition, not just in medical terms, but in the realities of daily life. Balancing, for example, treatment with work or school, navigating fragmented services, and coping with the emotional and social impact of chronic illness. Involving them is not just the right thing to do ethically, it is essential if we want care model to actually work in practice. Health systems are getting better at listening, but too often engagement with people with lived experience remain tokenistic, more of a box-ticking exercise than a genuine partnership. And listening alone is not enough. Equity matters. People's needs are shaped by age, gender, socioeconomic background, ethnicity, or religion. Without an equity lens, we risk designing care models that serve only the average patient while leaving the most vulnerable behind. That is why in JACARDI we are going further, ensuring that people living with this condition are not only heard, but actively shaping decisions, and that voices from diverse communities are represented. Our equity framework, for example, is built on 4 C's. The first one is cultural humility, then we have context and data, co-design, and inclusive communication. What we see is that when patient and community are meaningfully engaged in co-design, the solutions they propose are not only more relevant and acceptable, they are often more cost-effective. They tend to focus on what really matters in practice, avoiding unnecessary complexity. And I would like to mention a quote from Dr. Warner Slack, which used to say that patient is the largest and least utilized resource in healthcare. And I think JACARDI is proving that when we tap into this source, we can design care that is both better and more sustainable. In JACARDI, these principles are embedded in our methodology. Every pilot project should include an equity lens and begins with the establishment of a stakeholder board, as you were mentioning earlier, which includes, for example, patient associations, healthcare professionals, and other key actors. These boards are not symbolic. They are a formal mechanism to ensure people with lived experience are actively shaping priority, co-designing intervention, and helping evaluate their impact. This ensures that engagement is not only symbolic, but built into structure from the very beginning. And of course, meaningful engagement is not without challenges. It requires time, resources, willingness, as you were mentioning, willingness also to share power, and a genuine cultural shift in how we think about expertise. But when we listen deeply and act on what we hear, we end up with solutions that are more sustainable, equitable, and impactful. Integrated care will only succeed if it is co-designed with people it serves in all their diversity.
Yes, but still, there's always a risk that good pilots stay isolated. Why do you think integrated care solutions often remain fragmented? How can we ensure that what's being developed now, like here in our JACARDI project, becomes practice and not just a solution for a few?
Thank you for this question, Helena. I think that's a really crucial issue. Too often, promising integrated care models remain isolated pilots because they are not designed with sustainability, scalability, and system integration in mind from the start. Pilots conceived as a short-term project without mechanism for transferability, financing, and policy uptake risk becoming highland of excellence that fail to transform or influence the wider system. To overcome these, three elements, I think, are essential: stakeholder engagement, evidence, and transferability. Stakeholder engagement comes from engaging policymakers, health authority, and local stakeholders from day one, ensuring alignment with priority and resources. Then evidence requires rigorous assessment across multiple dimensions, as you already were mentioning within your work package 9 and pilot. And transferability demands structured platform for sharing lessons, adapting solutions to different contexts, and avoiding duplication. This is exactly the approach JACARDI takes. Our methodology embeds sustainability as a transversal principle. Pilots are designed from day one with long-term viability in mind, thinking about how innovation can be integrated, maintained, and scaled within health systems. In addition, JACARDI implements a structured pilot assessment framework that evaluates different key outcome dimensions, such as clinical effectiveness, patient experience, sustainability, distributional equity, and economic efficiency. These assessments generate robust evidence that validate pilots locally and support their transfer and scale up across countries. Creating practical integrated models can inspire system-wide change. In JACARDI, we strongly believe that the success of the project will not only be measured by the number of pilots implemented, but by the lasting change it enables in how care is delivered across Europe. And before we close, Helena, I would like to ask you a very critical question. When you think about the future, what does real success in integrated care across Europe mean to you?
Let me get a little sentimental here, especially because I'm quite sure, Benedetta, that as a public health expert, you will be able to give a much more solid professional take on it. So my own vision is that even with all the technological advancements and tools the future will bring, I believe that at the heart of it all, there will be and should be true human care. Not just healthcare professionals doing their jobs because this is their duty and that's what they are trained to do, but people who are truly driven by the desire to care, who want to find the best solutions for each patient and, of course, their families and their communities. And on the other side, I hope we will see patients who do not place all responsibility for their physical and mental health on professionals, but who feel a personal duty to take care of themselves, to nurture and protect their health with intention and accountability. If we can get there, then I think humanity itself becomes embedded in the system. And that's what I believe should be the true integrating element. Of course, that kind of change goes far beyond any individual care pathway improvement project. It's not just a question of systems or processes, it's a cultural change, and that always takes time. But let's turn to you now, Benedetta. What's your more pragmatic and global health principle on this?
Well, thank you, Helena. And I think after your sentimental answer, as you were mentioning, it is quite difficult to reply to this question. Well, looking to the future, I think success in integrated care across Europe will mean that every person living with diabetes, cardiovascular disease, or any non-communicable diseases experience care that is seamless, coordinated, and truly tailored to their needs, regardless of where they live, their background, or their circumstances. Integrated care should not be the exception. It should be the standard approach embedded across primary, secondary, and community health services. In this ideal future, health system will be truly person-centered, with patient and community actively shaping how care is designed and delivered. Decision would be guided by evidence, but also by lived experience, as we mentioned earlier, ensuring equity, inclusion, and respect for cultural, social, and personal diversity at every step. Systems would anticipate risk, support prevention, and enable early detection and self-management rather than reacting only when illness occurs. And health systems flourish when the voice of those they serve are at the heart of every decision. And I think to achieve this vision, maybe three fundamental shifts are needed. The first one might be, I can think about policy and governance. Policy and governance should prioritize integration and incentivize collaboration across services and sectors. Then health workforce and professional culture should embrace transdisciplinarity work, shared responsibility for patient outcome, and cultural humility. So the cultural humility is the ability to understand, respect, and adapt to diverse needs, values, and experience of the people they serve, which is one of the, as I was mentioning, one of the 4C embedded in JACARDI's equity framework. And then another important shift should be the data measurement and learning system that track outcome beyond clinical indicators, capturing patient experience, equity, and long-term sustainability, so that innovation can be tested, adapted, and scaled across contexts. For JACARDI, this vision guides everything we do. We are working to build practical, scalable models based on evidence and co-design with patient and community that can inspire real system-wide change. And success will not be a single intervention, but a transformation in how Europe thinks about the deliver's care. And this should be equitable, coordinated, sustainable, and centered on the person, not the disease. And if we achieve this, I think the impact will be profound. This is the ideal future, of course, and I see for integrated care in Europe, and it starts with putting people at the center, respecting and embracing their diversity, and designing care with them and not for them.
Thank you, Benedetta and Helena, for sharing your insights on such an interesting topic. We look forward to continuing to work together on this theme and making sure that all people living with diabetes have access to better care. To our listeners, thank you for joining us on this journey. We hope you find this discussion inspiring. If you have any questions or topics you would like us to explore in the next episodes, please reach out to us or leave a comment. Don't forget to subscribe to the IDF Europe podcast so you don't miss our upcoming episodes, where we will continue to explore important issues related to diabetes. Our series of podcast episodes on personalized and integrated care are supported by Air Liquide. See you next time.